Greetings from Howard University. Welcome to this edition of At Howard. We're so excited to have joining us today Dr. Lakshmi Krishnan, who is co-executive director of the Georgetown Howard Medical Humanities and Health Justice Center along with me, and Dr. Sharon Malone, who is our guest for today's conversation. We're really excited to have you learn a little bit more about a book that we have been talking about a lot, about grown women and the conversations that they should have, don't have, but will have after having read this book. Welcome to Howard.
Thank you so much for having me.
It's such a pleasure to have you join us. We want to start with having you tell us a little bit about what made you write this book.
Well, I wrote Grown Woman Talk because I would think throughout most of my career, not only did I see patients in the office, but I spent a lot of time navigating the healthcare journeys of my family, my friends, friends of friends. And the one thing that struck me was if these are people who are very smart women, they have access, they have good insurance, and if they walk out of an interaction with a doctor not understanding what actually is being asked of them, and not only that, but just how to navigate this crazy Byzantine medical system that we have right now. And I thought it would be perhaps a good thing for people to have sort of a roadmap. You know, there's so many things that we assume about what's going on in medicine, and a lot of that has changed. And you need to know what's changed and why and what your responsibilities are.
I resonated with this book on so many levels. As a woman of color, as a physician, I was just like cheering as I read this book. So could you talk to us about how your experiences as an OB-GYN in DC for 30 years of a career informed the shape, the structure, the content of this book?
Well, I was very fortunate in that I got to spend my entire career in DC in one practice, almost one location for almost 30 years. So I had the good fortune of being able to observe not only my patients as they aged, so I have many patients who I've seen through high school, college, childbirth, and now menopause. And I realized that is such a privilege that I have had, and I realized as I got towards the end of my career how much that was changing, and that so many of us are no longer going to have that experience where we can have that one-on-one relationship with a doctor throughout our lives. So even though my experience has been wonderful, I'm quite aware of the fact that that will not be the wave of the future. And that was also one of the reasons why I wanted to write this book, because somewhere along the way, things changed, and no one certainly asked us doctors about whether or not this is the way we wanted it to be. And certainly no one informed the patients. And I think that the more we know, the better we're able to advocate for ourselves when we're in that position.
I just have to ask a kind of follow-up to that, because hearing you say what has changed over 30 years, it's so hard to boil this down to a couple of things, but what would you say are some of the most striking or notable things that you noticed changing, and maybe that your patients picked up on as well, and that went into the book?
Well, I'll tell you this. I was present during probably the two most seismic changes in medicine, certainly in the past 50 years. And the first one happened just as I started private practice, and that was the introduction of managed care. Before that, and this really didn't start happening until like the late 80s, early 90s, where we went from a model where you go to the doctor, your doctor tells you, what they want you to do, you go get it done, your insurance pays for it, end of discussion. Well, that was a big change when we went to managed care, where now the patients are no longer really managed exclusively by the doctors, but there is a third party involved, and that is your insurance company and HMOs and the like. And when that happened, there was a lot of uproar about it. It was like, oh my God, what do you mean I have to ask? I have to get permission for things that your doctor, has recommended. Well, even though we complained mightily at the time, guess what? It never went back to the old way. And that was the first big change in how we, doctors and patients, interact. And I think the next one that happened, which started happening probably about 20 years ago, it happened slowly at first and then all at once, Well, and that is the introduction of private practices really disappearing. More and more now, the likelihood that your doctor is a sole proprietor and the owner of their practice and able to manage, that is going away. And I think when I wrote my book, at the time, the statistics were more like 70% of doctors' practices are no longer owned by the physicians. They are owned by either large hospital groups or they are owned by private equity groups who have come in and swooped in and bought up doctors' practices. And the reason for that is that it has become increasingly difficult for doctors trying to make ends meet. And so we were sort of ripe for the picking. But did anyone ask us if this is how we want it to work? No, they did not. But the consequence of that is that your doctor is now more likely to be an employee, not a business owner. And so when the first wave happened, the patients no longer belong to us, they belong to the insurance company. And now we're at the phase where doctors, even your physical space no longer belongs to you, nor do your employees. They're going to be managed by another third party. So where does that leave us and where does that leave you as a patient? It means that as a doctor, if it's not yours and you're not personally vested in that practice, it's causing more churn. Doctors are employees, and once you're an employee, you behave like employees in any other setting. Well, if this works for you, or if you want to move, you're going to move out. So there's much more turnover in the number of doctors. We've also got a situation where the technology has outpaced doctors' ability to use that technology. So we are at a disadvantage. And I think that patients feel that, because when doctors are employees, guess what else you're not in control of? Not only your office and your physical space and your employees, but you're not in control of your time. And so how much time you get to spend with the patient, how much time, what's your throughput going to be, that's really not dictated by you. So it's making doctors move faster. That means that you as a patient are going to get less time with that doctor. On average now, a patient gets about 5 to 7 minutes of doctor face time, which is not a lot. And so you have to know how to show up for that. If you're going to get 5 to 7 minutes, you better use that 5 to 7 minutes very wisely.
So we're here in the Chadwick A. Boseman School of Fine Arts in the Art Gallery, in part because the work that we do at the Medical Humanities Center suggests exactly the point that you're making, that we have to put the patient at the center of the conversation, and that there has to be a rightful kind of critique of the healthcare system. And part of what we hope to be able to do as academics who are thinking about medical humanities is to advocate along with doctors to put the patient's needs and the humanistic enterprise like at the fore of the conversation. You talk a lot in the book about experiences where you're putting the patient first. And for those who are not fortunate enough to come to you, and as much as we would like you to work forever, you won't, how do you suggest that patients, particularly Black women, women of color, use their time in the doctor's office? Lakshmi and I were talking about this, and we were just saying we're using so many of the concepts that you talk about, like this wellness journal. Like, we have to write down, what is our wish for wellness? What are the things that we need to make sure that we're making note of? Because we will only get 5 to 7 minutes in the room with the doctor, and you have to be prepared. Tell us a little bit about that.
Well, I start my book at the very beginning, which is just, how do you even choose a doctor? What's important, what's not? And many of us choose doctors the way we choose, a grocery store or, a good book to read. You just ask your friends, who do you see? And then that's sort of, we go through word of mouth recommendations for most of our doctors. But here is something that I think is important. We have got to learn how to be not only efficient but effective advocates for ourselves. And we also don't want to leave money on the table. You know, because just because a doctor is the best doctor for your friend, well, that doctor may not be on your insurance. Yeah. You know, that doctor may not take insurance. So how are you going to use the criteria if you don't know and you're not a medical professional? What do you look for when you're trying to, one, pick a doctor, and two, assemble your medical team? Because that's also important. I think that when we choose doctors, sometimes we'll say, okay, well, who's the best internist? Who's the best GYN? Who's the best cardiologist? Which is great, except for the fact that that may be very inefficient if those doctors are not part of the same system, if those doctors are not on your insurance plan, if those doctors don't know each other and know how to communicate. Because you would think in this day and time, well, we have the ability to communicate, you know, you can text, you can call, you can email. There is probably less communication between doctors now than there was 30 years ago when you just pick up the phone and call somebody. And that's a reality that patients need to be aware of, because I think that the assumption is, well, I have an electronic medical record,
That's
so
right.
You can access it, and why don't you just send my records over to the new doctor? Doesn't work like that. And it's not an unreasonable assumption to assume that it did. But that's not how it works. So these are kind of the logistical things that I talk about what's important about your family history and your personal health history, such that you bring that to the table when you see your doctor, certainly for the first time, so that's part of the getting to know you moment. But what's important? What's not? These are the kinds of things that you need to know that are very important data points. And I think it's going to require more of you. Now, it's good news and bad news, but that's what it is. You are going to have to take more control of what type of interaction you have with that doctor, because the chances are, more than not, you're going to see someone that you don't know and who doesn't know you. You may come back the next year and you may see yet again someone different, or you may see a nurse practitioner. So if you don't have the luxury of seeing patients the way I did, where I saw people for 30 years, I know your mother, I know your children, then you're going to have to be, the only person that knows your story is you. So you've got to show up knowing how to effectively tell that story to a new patient, to a new doctor, and to a new team, perhaps every time you walk in the door.
And you also talk about how storytelling can be used to our advantage and then sometimes to our disadvantage. Those moments where you know how to tell your story to your doctor may be the difference between a solution and not. But then sometimes there are those stories, myths that we also perpetuate. We love how you start the book, or at different points in the book, there's the Dear Sis.
Yes.
And then it ends, XO Dr. Sharon. What informed your storytelling practice, really to use stories as a way to get at telling this thing? You say, for instance, I'm here to cheer you on. I'm not here to chastise you.
Right.
Even though I felt so judged and seen about my ultra-processed foods. I knew better. But yes, tell us a little bit about structure, like what informs, and the music. There's so many different parts in the book that make it relatable so that it's not intimidating. I'm able to approach this in a way that I own my space, I own my health, but you also join us in that work.
Well, the way I wrote the book, I did not want it to be intimidating. I'm not trying to train anyone to be a doctor. I don't want you to know, I want you to know enough to advocate for yourself. And really, when I started writing the book, and I thought about it, and I've spent a lot of time in menopause world and perimenopause world, but I said, you know what? The midlife health journey is more than that. And I wanted the reader to understand a couple of things. One, yes, I'm writing this book as a doctor and I want to give you good advice, but I'm a mother, I'm a sister, I'm a daughter, and I have answered many of these questions for people that I love, and I want it to come with that tone. This is not someone who's really trying to tell you something or to shame you or to make you feel in any way inadequate about what you've been doing, because I think that we all can do better. You know, no matter where you enter this journey, we can all do better. And I think we want to do better. If we only knew exactly what to do and why it's important. Because the way I always practice was this, you know, when I talk to my patients, I say straight up, I'm trying to give you some good advice. This is the advice I would give my sister, and I would hope that she would follow. And if you take that tone, then people don't get put off by the message. So, and when you're trying to talk about things in a book that may be difficult, like cardiovascular disease, and talk about obesity and chronic stress, and all the other things that may befall us in midlife, you got to figure out a way to lighten it up a little bit. You know, and I think that the using the vehicle of storytelling is important, because that's really how we learn. You don't, if I just wrote a big treatise about all of these things and gave you charts and pie charts and graphs, your eyes would glaze over and you'd go to sleep. But when I tell you a story about a patient, or I tell you a story about a family member of mine, and I do use a lot of my family stories, then I think it sticks, because you can relate to the story even if you don't understand what some of the background information may be. But I wrote it to be accessible. I wrote it such that anybody from any age, and that's why I called it Grown Woman Talk, because anybody who's a grown woman can enter this book, whether it speaks to you at this particular moment, or it speaks to something that you are dealing with, your mother or parents. That is where I want the book to be. And if it lands that way and people feel seen and heard by the stories that I tell, then I've done my job.
Yes, absolutely.
So many questions I could ask after that. That was, I was like, yes. I guess a very specific question around, what do you think that we as doctors, as healthcare professionals, can do better in terms of that storytelling piece? And so much of that is implicit and explicit in the book already. But, you know, when I think about my own practice, I practice inpatient medicine. Our biggest failures, it's not because the technology is not there. It's not because the science is not there. It's communication, not understanding history and context of what our patients have been through, personal history and communal history, and really come back to communication. Like, it's like, you didn't know this, or someone didn't tell you this, or how was this explained to you? So one of our goals with the center is to help transform health professions education by bringing these concepts in. If you had like a couple of messages for those students at Howard and Georgetown who are on the path to becoming, you know, health professionals, what can we do better?
Well, you know, I think that one of the things that we can do better is in training our doctors to have them not only just to know the ins and outs of certain diseases and disease processes, but to have some cultural awareness of the communities and the people whom you serve. And I think that that sometimes is lost, because we in medicine, we treat diseases, we don't treat the patients, and we know that no disease exists out of the context in which it has been formed. And if you don't have a good sense of the cultural awareness, or what could be the things that are actually getting in the way of your patients not being compliant. Say, for instance, you know, and you know this, doctors get mad. Well, oh, I gave her this prescription and she didn't take it. Well, you need to understand why. Maybe she can't afford it. Maybe there are things that prescription is making her go to the bathroom 10 times a day, and she can't do that in her job. These are the kinds of things that we have to get to the bottom of. And I think in an ideal world, wouldn't it be great if everyone had the opportunity to see a doctor who was not only competent, but culturally sensitive and understanding and empathetic? That'd be great.
Yeah.
Well, that when I get to Nirvana, I'll let you know. But we have to, this is again something where we have to realize that even now, if we started today and said, you're absolutely right, Sharon, we need to start training doctors this way. Well, that's a 10, 12, 15-year journey that we're on. And part of what I wanted to do is to say, well, you know what? I use a saying from Bill Withers, because I have a lot of musical references in my book. And Bill Withers has this great quote where he says, when you're on your way to wonderful, when you get to just okay, you better stop and look around because that may be as far as you get. And that's sort of where we are. And I think that, even though there's a wide, opportunity, a big opportunity for us to do better in the future, we also have to deal with what we're dealing with here and now. And that's where it gets back to patient involvement. And I think that at some point in the not too distant future, and I think probably like now, we're going to have to understand that artificial intelligence will be a part of the doctor-patient interaction. There will be things that we have more of an opportunity to use that to our advantage rather than be afraid of it, because that is the only way we're going to expand our reach into communities that we don't have enough culturally competent doctors to service.
While we're waiting for Nirvana, you give us the path to this wellness wish list. Yeah. What do you talk to your patients about to say, make sure this is on your wellness wish list? Or here's how you begin to structure what that wish list should look like. And we do this for so many things. We want the perfect pair of black slacks. We want the perfect pair of black flats. We want the perfect earring, but we don't tend to think about our health in that way.
Exactly. I think the first place to start is to redefine what midlife and beyond looks like. Because I think that we all have a picture or a certain narrative in our head about how we think this journey is going to go. And if your experience has been watching older siblings or watching your parents sort of go in this period of decline as they age, and the decline starts way earlier than most people think, if that's your vision of what getting older looks like, then that's what you accept.
Yes.
And the first thing that I want to say is I want you to reimagine what being 50, 60, 70 looks like. What are the kinds of things that you want to be able to do at that age? Yeah. Don't look at what your mother's able to do or what your grandmother's able to do, because that should not be your journey. We have the capacity to understand that I want to be a person who can get on an airplane, off an airplane, and walk to the baggage claim without the assistance of someone who's in a wheelchair. These are the kind of, when I say the goals and your wellness, sort of wish list, how long, not just how long you live, but how long you live healthfully. Yeah. And that is the difference between your lifespan and your health span. And we've done a great job in a lot of instances in improving people's lifespans. Yeah. But the amount of time that people live healthfully is shrinking. And so to answer your question, what I want people to do is to start thinking about how you want to be at a particular given age, and then back that up and figure out, okay, well then what do I have to do now to ensure that that is my future? And if you expect a good outcome, then I think you can start working on it. I tell people all the time, I'm like, look, I am 65 years old and I feel great. I feel, I have invested and put time into the things that will increase not just my lifespan, but my health span, because I didn't really get a chance to see what all of that looks like. My mother died when I was 12 years old. And even though I have older siblings, I have not had that full experience of watching the aging process. I've lost two of my sisters prematurely. One died at 63, another died at 71, and that is a shortened lifespan. And so, I want to be a good model. I want you to be a good role model for the people to come after you, to know this is what 50 looks like. This is what 70 looks like. And guess what? It's not that bad. Yeah.
I'm curious when you became most aware of that, of the possibilities of what you want 50 to look like. And we were talking about lifespan and health span. I'm telling you, we were so buying all of these things. So I can remember literally the good fortune, my mother died, I think, prematurely as well, but I do remember very well, we would ask like my mother certain questions about why she did something, why she didn't do this or whatever, and she would just say, keep living. And so now my sisters and my cousins, we're on a group chat in the morning, and our like kind of resonating theme is, if keep living was a person, I'm it. We saw it and we still didn't have the conversations because somehow we didn't imagine we'd be 50 or 60. We knew we would live that long, but we thought somehow magically we weren't going to be what we saw.
Right.
Do you remember when you became aware that you wanted, this was your wellness wish list, like when I'm 50, I want this, when I'm 60, I want this, or was it, I'm aware of it now at 51. Now I'm very clear. This is what I want to be able to do. I want to be able to take a trip. I want to be able to travel. All the things that you can afford to do in retirement or as you are progressing in your career, your body has to cooperate as well.
Yeah. Exactly. Wouldn't that be a bummer if you finally get to the point in life where you don't have to get up and go to work every day, your children are gone, or whoever it is, and you are finally into you can say, wow, I come first now. Yes. And then to not be able to actualize that because of poor health, that would be the ultimate bummer. And then it's like, oh, and you get to live another 25 years just like that. Oh.
Or slowly, generously declining as you're going.
Right.
Yeah.
But you know where I think that we have already started to redefine what aging looks like in women. And that is because think about all the people now who have come forward, who have said, yes, I'm menopausal, and yes, I'm still vibrant. I can still be sexy. There is, Kamala Harris is 59 years old, soon to be 60, and look at her. I mean, she's the young, vibrant, candidate in this race. Yeah. And I'm like, we have never said a 60-year-old woman, oh, look at that youngster. But this is how we are changing the face of what we expect it to be. And I have to tell you, I thought about it because we laughed. I was together with my classmates this past weekend, and we were talking about one of our advisors, and she's still alive. Now, I was in a sorority, pledged almost 45 years ago. And I realized, I said, well, my God, she was our advisor. And I'm like, that was 45 years ago. She's still alive. She couldn't have possibly been as old as I thought she was at the time.
Yes.
I'm like, would she be 120 now? So I said, when you're young, and again, how the generation before us aged is very different than how we age. You can't tell, I defy someone to tell the difference between a 50-year-old and a 42-year-old or whatever. We're sort of, again, that our expectations for what we're going to be at what age has changed. And so I also had the extra luxury, when you're the youngest of 8 kids, and I'm the youngest by a lot, you get to see kind of what worked and what didn't work in terms of lifestyle. And I'm a lot of things, but I'm not a slow learner. And I was like, I bet I'm not going to do that. Yeah. Or, figure out ways to sort of change that trajectory. Because the one message that I get, that I want to impart to my patients is this. Your family history is important. It really is. But your family history only tells you really one important thing, and that is what you are susceptible to. Most of the things that befall us in old age are not because we are genetically predisposed to those things. It is because we share environments, we share habits, behaviors, all of the things that may affect your outcome. So I say know your family history, not to discourage you, because I have a very terrible family history when it comes to cancer, but you learn from that. And it's as if someone put up a signpost and it says bridge out ahead. And if you were on the road and the sign said bridge out ahead, you don't put your foot on the gas. That's right. It gives you an opportunity. The sooner you see it, then well, I better at least slow down. But preferably, let's just stop and turn around and go in a different direction. Yeah. And that's really the message. So, yes, know your family history, know what's important. Most things are not genetically programmed. A lot of things you do have control over, and that's the message of empowerment that I want women to get. Don't, say, oh, woe is me. say that should be motivating for you for trying to figure out how not to get to that same destination.
Yeah, that's a great part of the story, I think, because I think I too was one of those folks who said, genetically, this is just, it just is what it is. We take the positive. I love my mother's skin. I'm happy about it. I'm like, oh, this is just genetically. But then like when the extra weight comes after menopause, I'm like, I'm just my mama's apple.
Right.
No, because I'm eating what she ate. Yeah.
Right. And I'm not, that the whole notion of exercise, which I spend a lot of time talking about, a lot of the things that I talk about in the book, and at the end of each chapter, I try to make it easy such that even if you read it and you can't remember, then at the end of each chapter, there's a list of like, okay, let me say it and let me say it again. But just something like the importance of exercise, why it's important. I have always found it to be the case that when I'm trying to give advice to patients, one, it's helpful to give the advice in advance of whenever the condition is that we're going to talk about. Because once I know your family history and I know it's this, then I can give you what is considered anticipatory guidance, so you know how to avoid these things. But I want you to know that how we navigate this journey, you can choose. Just my mother used to say a lot of things, but you can make your bed hard or you can make it easy. That's so right. You decide which way you're going to do it. And I think that if we knew what to do, I think we'd do it. And I think that people respond to positive reinforcement, not negative reinforcement. I would never approach a patient to come in and say, who's gained weight from one year to the next and say, you need to lose some weight, no. If patients people want to do better. Yeah. But if you explain to them why it's important, what are the things, one of the things I talk about a lot about weight is that after a certain age, I don't want to talk about weight per se, because the more important thing is what are your health parameters. If you are healthy and you do not have what we call the metabolic syndrome, which is high blood pressure, elevated cholesterol and triglycerides, and diabetes, these types of things, whatever weight you are, I want you to still exercise. You don't exercise to lose weight. That's not the point, because you don't, by the way. I'm sure everybody knows that, and you'll be so sorely disappointed. You're like, oh, I've been going to the gym every day. And it's like, I don't care. You're healthier for having gone to the gym. So don't stop simply because you say, I've been going to the gym for 6 months and I haven't lost any weight. Well, guess what you have done? You've improved your heart health. You've probably done something for your blood pressure, your blood sugar, helping maintain all that stress level, and you feel better. So I'll take it. And if you give people that message as opposed to go lose weight, then, I think you're going to be much more successful. And I think patients are much more likely to sign up for that rather than say, oh, I don't even want to see her because I've gained another 10 pounds this year, and that's happened. Oh, don't make me get on the scale. It's like, no, I want you to, but not to, more often than not, I want you to get on the scale because I want to encourage you. I tell my patients all the time, if they come in and if they haven't lost any weight and you're a woman above age 50, if you haven't gained any weight from last year to this year, then I say, well, congratulations, because most people will gain anywhere from 2 to 3 pounds in a year. So I'm going to give you credit for the 2 or 3 pounds that you didn't gain. Yay, let's celebrate that. And then we'll work on the things a little bit at a time. But I don't ever want to give anyone the impression that the point of exercising and the point of all of this is to lose weight or to be in a certain size, jeans. And I don't want you to be. I certainly don't weigh what I weighed 25 or 30 years ago. Okay, and I'm not trying, that's a fool's errand if I thought that I was ever going to get in those college jeans again. That's not happening. So I might as well say, it's what it is. Am I healthy? Are all my parameters good? Then I'm good. I'm going to be okay where that is. And that's the other thing we have to do as women. We have to say, if I'm healthy, I'm okay. Do not adhere to some outside standard about what you think you should look like and what you should be able to wear. No, That's a part of being a grown woman. You realize, okay, I had that day and that day is past. We're on to something else now.
Yeah.
I love that. I love that. I'm just thinking wellness list for our whole team. We're gonna do it as a team exercise
yes.
too. I'm adding things to my wellness list as we talk. And just one thing I wanted to mention was I'm so taken by how much metaphor and story you use just even in this conversation, and thinking about how much there's a message here about how good doctoring and a good patient-physician relationship is about storytelling and teaching, being a good teacher. So kind of a bit of a pivot, but one of the things that has come up a lot since our center launched and we announced our first year's theme, which is story and lore. Really, what are the things that folks talk about outside of institutions that aren't recorded in traditional ways? And a lot, as we started putting out those calls, a lot of what started coming in was how many people in DC feel unheard, dismissed, ignored by the health establishment, especially women. And so I guess the question for you is, what strategies would you recommend for women of color, Black women who are being dismissed and further marginalized by the healthcare system?
I think that is the history of women and the medical profession. Yeah. Women have always been dismissed. We've been told it's all in your head, or we have really accepted an unacceptable amount of women's suffering. And that we sort of chalk it up to, that's just women. You suffer from cramps, you suffer from migraines, you suffer through childbirth. And we have sort of incorporated that language into the lexicon. And we as doctors have become insensitive to that because, it's when women complain. Well, we complain because these are things that are distressing to us. And to not have those things addressed, or to be told, no, dear, don't worry about it, or that's normal. And particularly when it comes to menopause, I think this is one of the areas that, I have spent a lot of time in and talking about the disparities in menopause and menopause care, and what we have allowed women to endure is, to me, unconscionable. Mm-hmm. I think we should be able to discuss these things. We should be able to give women good information. I think that whether or not how you sort of navigate this whole menopause journey really is going to depend on, one, that it's coming, yeah. And two, that that menopause is way more than a hot flash. There are probably over 34 symptoms of menopause that start way earlier than we would ever expect, because you think, menopause, that happens to old ladies. No, menopause happens, and the menopausal transition happens sometimes to 30-somethings, to 40-somethings. And so we've got two problems. One, not enough patient education about what to expect, but we also have the additional problem of physicians not knowing and understanding and seeing and hearing what women are saying. And if you don't acknowledge that, then how on earth are you going to treat that person that's sitting in front of you? Not some textbook. You can't do a blood test and say, it's normal, so you're fine. No, I just told you it's not fine. And that's where I think we certainly can do better, and that is to be able to listen and to believe the person that's sitting in front of you, because she didn't come in here to make up a story. She's telling you her story. So listen and address it.
You also suggest that when we're in the position where we don't feel heard by our doctors, that you probably should consider changing if it's an option.
Yes.
Certainly feeling comfortable enough to advocate for yourself. I think we tend to think about doctors as people who are much smarter than we are, who know what they're doing, who are thinking exclusively about you in that moment, when the reality is a lot of things are happening. And if you ask your doctor to slow down and hear you, the odds that your doctor will actually do that are pretty high.
They will, because again, I don't think doctors are out here trying to do a bad job. Yeah. Let's say this. I think that doctors are squeezed for the reasons that I talked about in the beginning, because they're being asked to do more and more work with less and less. And so, and then the treatment options are, much more varied now. And to have a fulsome conversation takes a lot of time. And that is really in short supply in most doctors' offices. So that's why I said, the things that I write about, even the chapters that I discuss things like female troubles, and that was something my mother used to say. I was like, what the hell is female troubles? Yeah. But that was everything from fibroids to cramps to menopause. It was like whatever it is was all fell under female troubles. But being able to, I don't want you to, again, I didn't write this book to make women have to be doctors and be well-versed, but I want to give you enough information such that when you show up, you know what questions to ask. You've thought about it in advance and you have learned how to tell your story. Because the one thing that I don't think that people really understand is that medicine and history taking, it's all about storytelling. You tell your story to me, I interpret your story, and when we're residents and we're in training, then I have to take your story, synthesize it, and tell that story to someone else, such that we can together come up with an acceptable ending for your story, or a resolution for your story. And if you're not a good storyteller, the old garbage in, garbage out. If you tell me a story that's inaccurate, or you tell me a story that's incomplete, then I will not be able to make a good plan for you. And so that's why I said the importance of storytelling. I mean, I cannot emphasize that enough. And that this is what we should look at this as we're a team. And we are on the team, and our goal, we should have a common goal, is to make you be the best person you can be, to be the healthiest person you can be. And it's not an adversarial relationship, it's teamwork.
Yeah. So I think I'll have one more question, and Lakshmi will have one more question. I think mine is going to be what surprised you the most about the book, maybe its reception or the experience that you've had post writing the book.
There are two things that surprised me, and one of which is that as I started doing research, I'm like, oh, I got this. I know, I have a pretty good grasp certainly on menopause and perimenopause. But as I started to delve into the other things, what surprised me was how large the disparities are when it comes to Black women in this country. It's not just about maternal mortality. 2 to 3 times, yes. That same health disparity extends to cardiovascular disease, to cancer, to high blood pressure, diabetes, everything. That you can almost apply that same sort of 2 to 3 times in terms of outcomes, the worse outcomes for Black women. Alzheimer's, this was one I think that surprised me the most. I did not realize that for Alzheimer's, women are twice as likely to be diagnosed with Alzheimer's as men. I was like, But when you think about it, go into a nursing home and see who's there.
Yeah.
Black women are twice as likely to be diagnosed with cognitive decline or Alzheimer's than white women. Now, that was surprising to me. And I said, wow, I did not know that. I've been in my little corner of medicine, and I didn't venture out to know how bad the disparities are. And what I really wanted to do was to sort of create the story that shows you is that when we talk about healthcare disparities, one, they're not isolated, they are pervasive throughout all phases of our lives. And to highlight, okay, we've talked about the disparities. Now, what are we going to do about it?
Yeah.
Because I think that the reason why we have not effectively advocated for ourselves is because we didn't know. We're doing a good job now, and we're sort of brought the maternal mortality and infant mortality out, and we should. But I want to talk about all of it. And once you sort of get people activated and they realize, wait a minute, why don't I have access to this? Or why don't we know why the disparities exist. And it's not enough to blame the patients, because I think that's where the conversation has, oh, if you would just stop doing this and if you would just stop doing that, then it's your fault. It's your hair perm. It's you're too fat. It's this, it's that. It's all the things that we blame people for, who are the unfortunate benefactors of these healthcare disparities. We can do better. And we must, and that's part of what I want to do. And those things were surprising, even to me, for someone who's been doing this for 30 years. But I think, if you say the thing that's been most surprising to me when I talk about these issues in audiences is, one, how receptive people are to this message. And two, you can say perimenopause and menopause, and I could be here all day, because it doesn't matter. Yeah. Black, white, rich, poor, LA, Atlanta, women do not know enough about this phase of life. And it is almost, and I keep thinking, I've been talking about it so much, I go, well, I already said that. Didn't you know that? No. Every room I go in, this message is so well received, and they are saying, you know what, I never thought about it that way. Let me go do a little homework and let me make sure that I know how to advocate for myself. And, again, don't accept it, ladies. We can do a lot of things. And one of the things that I want us to do is to be better advocates for ourselves.
Yeah. That was just lovely, and anticipated what was going to be my final question, which is kind of a doozy, but if anyone can do it, which is that you mentioned social determinants of health. We know about political determinants of health, that there's so much work that you are doing and that patients and communities are doing at that level of the clinical encounter, but what would you say is a policy change or something that we should be advocating for amongst ourselves in our communities, and honestly to the powers that be?
That is an excellent question, and what it is, it sort of falls under what I say my big A advocacy is, and that is, finding out that women, as women, we are 51% of the population. NIH, which funds research, had, and as of the writing of my book, they had a $45 billion budget that they funded research for. Of that $45 billion, less than 11% of that went to conditions that either primarily or exclusively affect women. Now, when you talk about women in midlife, and most of that goes to breast cancer and some of the other more common things, but the things that women suffer from, we should all be appalled by how little money goes to perimenopause, menopause, migraines, depression, things that disproportionately affect women. And I think that, again, now only 11%, well, wait a minute, we are 60% of the voting population. What gets funded depends tremendously on not only the person that's making the funding decisions, it is also dependent upon who the researchers are, who's deciding what questions are important enough to answer or to ask. And until we get a more diverse, I think, people in the research world that are trying to answer some of the questions that we're still asking, that we've been asking for 30 years and have been left to the side, this is where policy and politics matter. Because there are only so many things we can do on an individual basis. And there are certain things that we have to go back to our legislators. The policing of women's bodies has always been political. So I say political, not partisan, political. So if you want to make sure that the questions that we still have are being answered, then it matters. Go look at the people that you're going to vote for. And I'm not telling you who to vote for, but look through that prism and say, what is your policy on women's health? How are we going to make sure that these things get funded? It's one thing to talk about them, but no, you need to do research. And I think that we also need to hold our academic institutions accountable, because again, you're deciding what you're going to study, what you're not going to study, and unfortunately that's driven by what gets funded. But you also have to make sure that women are adequately included in trials and women of color are adequately included in trials. And it's not enough to say, I put an ad up and no one answered. There are particular ways that you recruit for people if you find it important to have them be in part of your study. And I think those are the kinds of things that now we're aware, and now we can put on our big A advocacy hat and say, I need you to do better, NIH. I need you to do better, National Cancer Institute. I need you to do better, American Heart Association. All of these institutions who are out there that are driving the conversation, well then we're saying, include us in the conversation.
Thank you so much for joining us today, but more importantly, thank you so much for the book. Grown Woman Talk is available at your local and independent bookstores, online too, but really at your local and independent bookstores, especially if you are in our viewing audience. We have to say thank you to the Chadwick A. Boseman School of Fine Arts and the gallery, which we hope you will visit. And finally, if you want to learn more about the medical humanities initiatives at Howard and Georgetown, you can visit www.mhhj.org. And of course, we hope that you're already a sustaining member of WHUT. Thank you all. And thank you again, Dr. Malone.
Thank you for having me.
Thank you.
This program was produced by WHUT and made possible by contributions from viewers like you. For more information on this program or any other program, please visit our website at WHUT.org. Thank you.